Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor tamer, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. Today we will discuss on a very rare topic, that is Lynch syndrome. It is an inherited condition that increases a person's chance of getting certain types of cancer, often at a younger age than usual. The good news is, if it's caught early, there are ways to manage the risk and even prevent some of the cancers. To help us understand this better, we have with us Dr. Krishnamani, a medical expert who will explain what Lynch syndrome is, how it is detected, and what steps people and the family members can take if it runs in their genes. Without much further ado, let me begin by introducing our doctor to you. Dr. Krishnamani has extensive expertise in managing a wide range of cancers, including both solid and hematological malignancies. He is skilled in managing oncological emergencies as well. He has been actively involved in academic contributions and professional development. He has participated in various national and international conferences and seminars and has also been conducting a few workshops. He has been he has been associated with AOI hospitals in Hyderabad since the past decade. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. Thank you. And today, as you said, we'll talk a little bit about uh, Lynch syndrome, which is not so uncommon, but at the same time, we don't diagnose it that frequently also. So just let's discuss something about what is this syndrome and its other features.
So, sir, first, can you tell me what exactly is this Lynch syndrome?
So what is a syndrome? Syndrome means it's a group of findings in a person. Okay. So syndrome is a constellation of symptoms, we say. So Lynch syndrome is a syndrome in which the patients have an increased risk of certain cancers, like uh, stomach cancers, esophagus cancers, pancreas cancer, colorectal cancer, endometrium, ovary, prostate, urinary cancers, etc. So in this syndrome, compared to a general population or a general person, the patient who has Lynch syndrome has a high risk of these cancers. And it is a genetic condition. It is called an autosomal dominant condition. Okay. What is an autosomal dominant? If you have one affected parent, okay, father and mother, and imagine the father is affected and they have four kids, two of them will be affected with this cancer or this syndrome. So that is autosomal dominant. Okay, there is a divided penetrance between the boy and the girl. So Lynch syndrome is a genetic condition. It's an autosomal dominant condition, and there is an increased risk of many cancers, more commonly colorectal cancer, endometrial, ovary, genitourinary, prostate.
How is it different from the other hereditary cancer syndromes?
They are different. In colorectal cancers, for example, you have familial adenomatous polyposis. That's because of a mutation in the 5 chromosome. This is Lynch is called non-polyposis. There are polyps are not seen. So that is called FAP. More than hundreds and thousands of polyps are seen in the colon. Polyps are cauliflower growths. In Lynch, you don't see polyps in the colon. FAP is due to 5 chromosome involvement. Lynch syndrome is due to mismatch repair gene mutations, MMR mutations, we say. Okay. Now, for endometrial cancer, for ovarian cancer, you get Lynch syndrome. But in ovarian cancer, the commonest genetic is also probably a disease called BRCA1 and 2, which we discussed 2, 3 sessions back. BRCA mutations are very common in ovarian cancer. But in BRCA, what do you get? You get breast ovarian cancer, pancreas, and prostate cancers. That's a different gene. But here you have a MMR deficiency, and here you have different set of cancers. Here you don't see pancreas. Here you don't see breast that often. So That is how Lynch differs from different other conditions.
What can you tell us about the prevalence of this condition among the two genders and also among age groups?
Mm, See, the Lynch syndrome is responsible for approximately 3% of colorectal cancers. Okay, so amongst the colorectal, it is responsible for 3%, and because it's autosomal dominant, it is seen both the genders. And age-wise, obviously, in any syndromic cancer, you will see it at an earlier age. So Lynch syndrome patients probably develop cancers much younger, or they do generally develop cancers younger than the general population. So if a colorectal cancer is commonly seen at 50 or 60, in Lynch, you will see at 30 or 40.
And how is it clinically diagnosed? Before we come to the diagnosis, how do you see the clinical signs and symptoms of this syndrome in patients?
No, if you have colorectal cancer, what will you have? You will have bleeding, you'll have anemia, you'll have constipation, okay, blood in the stool. If you have endometrial cancer, you'll have vaginal bleeding, you'll have pain, pelvic pain. If you have ovarian cancer, you have pelvic pain, you have abdominal distension, bloating. If you have stomach cancer, you may have bleeding in the stool, you may have loss of appetite, early satiety, weight loss. So Lynch syndrome doesn't have a clinical feature. The cancer which it causes will have the clinical features.
Would the same apply for the diagnostic part as well?
So the diagnosis is different, right? How do you diagnose Lynch syndrome? So ideally, there are certain criteria. Anybody who has endometrial cancer below 50 years, think of Lynch. Anybody who has colorectal cancer below 50 years, think of Lynch. Any colorectal cancer also, nowadays they say, start working up for Lynch syndrome. Think of Lynch syndrome. If you have a first degree relative, your uncle, sorry, your mom or your dad or your brother or sister with Lynch, you work up for Lynch. If you have three family members and three have different cancers attributed to Lynch, then think of Lynch. Okay. If you yourself have Lynch, obviously you are screened for it or you are tested for it. So these are all the uh, what do you say, the red flags, which will tell you that somebody has Lynch or you should test the person for Lynch. So suppose somebody has less than 50, suppose a young colorectal cancer patient, do Lynch workup, young endometrial cancer, do Lynch workup, three or more family members with Lynch-like cancers, test this guy, one first degree relative with Lynch-like cancer, test this guy, two successive generations with Lynch cancer, test this guy. So who should be tested? This is the guy who should be tested. And who are all, why should he be tested? Because of this pedigree he has.
So, typically, at what age should a person be tested if his successors, if the previous generations are having those Lynch associated cancers?
No, it is see, if your previous generations or anybody in this criteria has, you just need to do a blood test. So do it at 20, 25. At that age group, you do a blood test. If you have the germline mutation, then you have Lynch syndrome. So at what age you screen is your next question. Okay, so I believe you're also thinking of at what age you will screen. So screening is different, testing is different.
Okay.
Testing means you're first of all seeing whether I have the Lynch syndrome. Now, if I have Lynch syndrome, when will you start uh, testing me so that I don't develop cancer? So there are two parts to this question. One is testing for Lynch syndrome. Whom will you test for Lynch syndrome? We told you everything. Whom all you should test. Whom you should test if you have first degree relative, two generations, three people having Lynch like cancer, anybody who has colorectal or endometrial below 50 years, all that. Now, what is that Lynch syndrome test? It's a germline test done in the blood. If this guy is positive, now he's at a risk of all these cancers, then you should begin screening for this guy. Now, when will you do screening? For colorectal cancer, your screening will start at 25, 30 years. Every 2 years, you do a colonoscopy. For endometrial cancer, start screening at the age of 30, 35 years. Every 1 or 2 years, you do a transvaginal ultrasound. Ovarian cancer, you can do a CA-125 or an ultrasound. Okay. Stomach cancer, there is nothing specific, but you can do endoscopies every 1 or 2 years. So for an affected individual, every 1 to 2 years, to reduce the chance of the disease coming or to catch the cancer early, more commonly endometrium and colorectal, you will start doing these tests from beginning the ages of 25, 30 or 30, 35, which is a very young age, because this cancer develops in a young age and you want to pick it up early so that you can cure these guys.
Is it possible for someone to have Lynch syndrome even though his predecessors don't have it, or those associated cancers? Can it just pop up in one generation of the individual?
Yes, yes, yes. So any colorectal cancer, do a Lynch workup. Any colorectal endometrial below 50, 100% do a Lynch workup, irrespective of family history.
Okay. What is the lifetime cancer risk in these individuals who are having Lynch syndrome?
For colorectal cancer is around 80%. For endometrium is around 60%. The average is 5% in the general population. So Lynch syndrome is a general population. If this person has a 5% risk, this person has a around 80% or less than 80% risk. Endometrial cancer, if it is 3 to 5%, it is 60%. Stomach cancer is 1 to 2%, is 15%. So lifetime risk is much higher. So Lynch syndrome guy has a high risk of cancer compared to a normal individual.
Is it also true that even though may be at risk, but the individual may not even develop those cancers?
Definitely. That's why you're screening them. Not everybody will develop cancer. So in Lynch syndrome, what are the commonest cancers? The commonest is endometrium. Around 57-60% patients develop. Next is colorectal, around 50% patients develop. All your stomach, gallbladder, duodenum, prostate, they're all single digits. So if somebody has Lynch syndrome, the highest chance of he getting is an endometrium, he or she is getting is an endometrium or a colorectal. And that individual of Lynch syndrome has a high risk compared to the normal person.
Now, how do you go about treating the individual? So, firstly, for a person who has been diagnosed with Lynch syndrome and another person who has been continuously screened for the syndrome.
You will only treat if they have cancer, right? You will not treat if they don't have cancer.
So, if the person is suspected to have the Lynch syndrome, there would not be any particular treatment or line of treatment for that person.
Studies have proven that aspirin reduces the risk of colorectal cancer, so you can give that. Okay.
Okay.
Uh, Surgeries have been suggested. Some people do hysterectomies for women who have completed their family beyond 40, 45 years. Okay. Otherwise, surgically or whatever way, screening is important for Lynch. Diagnosis is important for Lynch. But treatment-wise, you'll only do it once you develop cancer.
So, supposing a family member has been screened for the Lynch syndrome, what would be the next step? What would be the next step for him as a patient's journey of someone who could have it?
Keep him under close follow-up. That's all, and test his first degree siblings for germline mutations, so
Are
that
there
see whether they
any?
have Lynch or not.
Is it that we can modify this person to not have the cancer by any lifestyle modifications?
Yes, avoid obesity, avoid junk food, less oil, more fiber, lots of fruits, greens, and vegetables, prophylactic aspirin, maybe yoga, exercise. All these things help you to reduce the colorectal. Avoid smoking and alcohol. All these help you in avoid oral contraceptive pills, avoid tamoxifen for endometrial cancer. Okay, timely food, healthy food for stomach cancers. So all these add up to your overall to reduce the incidence of development of cancers.
Does genetic counseling also play a role for these
Big
people?
role. So you should know. See, it's a genetic disease. It's an autosomal dominant disease. Whom will you test? These are called modified Bethesda or Amsterdam criteria. So if you have these features you should test these patients. How will you do? So if somebody has cancer, you will test their tumor for MSI. We discussed that 2-3 weeks back, microsatellite instability. If your MSI high, okay, then you have to do genetic testing. In that you look for certain genes, MMR genes, MLH1, PMS2, BRAF gene. If you have any of these, you will probably be having Lynch syndrome. Got it? So genetic counseling is extremely important for the patient. You do it on the tumor. If the patient has Lynch syndrome based on MMR and MSI, you do it on the first degree relatives on the blood so that they don't develop cancer tomorrow.
So, sir, we have all heard about pre-marital testing, which is going on in today's scenario. So basically, like couples who are going to get married, they would want to, like, get all the genetic testing done so that they know what kind of diseases can be expected from their partners. So is this something that can be included in those genetic tests as well? Do they include this?
You should
No.
understand, no, that has a lot of implications. Simply, you cannot do genetic tests because it has a lot of psychological impact also. Imagine you're going to tell a girl that you have Lynch syndrome when she is in her 20 and say that you have a lifetime risk of endometrial cancer of close to 50-60%. She may never develop endometrial cancer, but today you have put that thought into her head at the age of 20 that she may have endometrial cancer. If she commits suicide, so genetic counseling is a very powerful tool. It has to be dealt with very carefully, and you should be very cautious when you are doing that. So you cannot just put it as a in a box and say that all couples who are going to get married get BRCA done, get this one done. Okay, if I am negative, will you 100% tell me I will not get breast cancer tomorrow? Or if I am positive, will you tell me that I will 100% get endometrial cancer or colorectal cancer tomorrow? So that is why there are criteria to choose who should be tested. And if they are positive, test their first degree relatives. And how to be tested? You will do MSI. If your MSI high, you have germline testing. If you are MLH1 or MLH plus PMS2, we say in the molecular testing, this is all done on the tumor. Then we do BRAF. You may not have Lynch then. If you have other mutations like MSH6, you may have Lynch. If you are MMR proficient, we say MSI stable, MSS we call that. Then again, you don't have Lynch. So there are a lot of things to go into it, and it involves IHC, molecular methods, it involves genetic counseling, an oncologist, geneticist.
Okay. So we move on to bursting some of the myths. So the first one is that only people with a strong family history of cancer can have Lynch syndrome.
No, any colorectal cancer, work up for Lynch syndrome.
If you test positive for Lynch syndrome, you will definitely get cancer.
No, you have a higher risk compared to the general population.
Men don't need to worry about Lynch syndrome even if there's history of uterine or ovarian cancer in the family.
No, men can get colorectal cancer, prostate cancers, genitourinary cancers.
If you feel fine, there's no need to test or screen for Lynch syndrome.
No, if you have disease, you have to be tested. If you have certain first degree relatives, or so if you fall in the criteria like the modified Amsterdam and Bethesda criteria, you have to test yourself for Lynch.
Okay, sir. Sir, a summary of today's informative session.
Lynch is common, but we don't diagnose it commonly because even clinicians don't know much about it. It is called HNPCC, hereditary non-polyposis cancer. That is, there are no polyps in the colon. These patients can get variety of cancers, commonly colorectal endometrium. Screening should be done once in 2 years or every year, beginning the ages of 25 or 30 for colorectal endometrium and stomach cancers, colorectal with colonoscopies. The risk is very high compared to the general population. But if we take adequate measures and screening, we can mitigate the risk. And there are certain features to diagnose Lynch, like patients who have first degree relatives or two generations involved or three Lynch syndrome variants, anybody with colorectal or endometrium cancer below 50 years or young patients, they have to get tested. And if you are tested and you are positive for Lynch, test your first degree relatives and screen them. So in this way, you are diagnosing a genetic disease, you're screening individuals, uh, you are testing in first degree relatives, and you're screening those people so that they don't develop cancer. And it is very common. It causes 3% of colorectal cancers and also endometrial cancers. So it's better we start opening our mind that this syndrome should be detected so that we are able to approach our other patients differently.
Thank you for this informative session, sir. Sir, can you also shed some light about the second opinion campaign which is being done by you for cancer patients who would want to get a second opinion from a doctor?
So, as we've always been saying on Cancer Reach, we want cancer information to be available to people and people to be able to reach Cancer Reach. So, Second Opinion campaign is there. It's free of cost. We have a WhatsApp number. Patients can put their reports on it. We will reply to them with the best uh, knowledge possible based on those reports within a turnaround time of 1 to 2 days. Also, they can put their information on Facebook or on Insta handle or on YouTube handles, and which way reply. And this is purely so that they get a professional medical oncology opinion or an oncology opinion, so that then they can continue their treatment wherever they want.
Thank you for joining us for today's session, sir. Thank you for shedding light on Lynch syndrome, which has not been very popularly discussed on social media sites. Thank you for your time, sir. We hope to see you again on next Friday.
Thank you so much.
Thank you, sir.